Oh no, no, I'm just configuring a few streaming key with
Oh,
Facebook and YouTube, and no, we just give it a minute or two for all the attendee to join us. Okay, now it's Facebook. All right, let's go Facebook. Okay, Facebook is on. All right, let's see participants. James Barnes. Okay. Hi, Christy. How are you? All right, Dr. Sepilian, I think it's the time. So whenever you're ready, we can get started. It.
okay, very good. Thank you very much for this invitation, and thank you very much for organizing this. Really, we're happy to be collaborating Pacific Fertility Center with Patriot Conceptions. Um, and this is a very important topic that we all should learn as much about. So let's go ahead and move forward. Today we're going to talk about IVF, and we'll touch upon on third-party reproduction. Just to introduce myself, my name is Dr. Vicken Sepilian. I'm a double board certified reproductive endocrinologist, as well as an obstetrician and gynecologist, fellowship trained, and have the highest level of board certification to practice in this field. Um, I practice in Southern California, in Westwood and Glendale, California, as well as do virtual visits and see patients from all over the world. Areas that I focus on are IVF, pre-implantation genetic testing, and third-party reproduction with egg donation and surrogacy, as well as egg freezing. Um, so today we're going to focus on one of the most effective treatments to tackle infertility, which is called in vitro fertilization. Um, and there are multiple treatments to help couples who are facing infertility. However, for the sake of just keeping the scope of this presentation, we're going to focus on in vitro fertilization today. In vitro fertilization, or IVF, is not the only treatment, but it is the most effective treatment. So essentially, IVF is the type of treatment where as this schematic shows, where an egg is removed from the ovary of a woman, and then that egg is fertilized in the lab setting using a partner's sperm. Then that fertilized egg is allowed to develop, which is referred to as an embryo. And then once that embryo is at an ideal stage for implantation, that embryo that subsequently is placed inside of the uterus so that that embryo will implant, and a pregnancy can result. So these are the stages of how pregnancy occurs naturally. On any given month, receiving signals from the brain. The ovary makes an egg. That egg then develops and matures. And again, when the proper level of maturity is achieved, that egg then releases and is picked up by the fallopian tube. These are the reproductive organs in a woman. If at that time intercourse took place and a normal amount of sperm is deposited in the vagina, then those sperms will be able to swim through the cervical canal, up the uterine cavity, through the fallopian tubes, and meet the egg that has been released and fertilize that egg. And then what ends up happening is that fertilized egg develops into an embryo. Approximately a week later, it arrives into the uterus. So by doing in vitro fertilization, essentially we're duplicating all these steps that occur naturally inside of the body, but we're duplicating those steps in a nurturing environment in the lab setting. So the maturation of the egg, we have ways of doing that. Fertilization of the egg, again, we have ways of doing that, which we'll discuss in a few slides. So this is what an ovary looks like under ultrasound. If you see this is usually an egg that is growing. Under natural circumstances on any given month, the ovary makes one egg. Oftentimes when we do in vitro fertilization, our goal is to maximize the impact of that one in vitro fertilization cycle. So what we do is we most of the time stimulate the ovaries so that the ovary gives us multiple eggs, so that from one cycle we are able to get multiple embryos to work with. So essentially, this is what an ovary looks like once it has been stimulated. These dark circles here, or triangles as it looks like, these are all follicles. Follicles are fluid-filled sacs that are in the ovary that contain the egg inside. So once we stimulate the ovary, this is what it looks like, and our goal is to get multiple eggs so that we're able to assure that that couple from those multiple eggs has some normal embryos to work with. So once the eggs are stimulated, or the ovaries are stimulated, and it's determined that the follicles are ready, we do the egg retrieval procedure. This is an outpatient office-based procedure that's done under ultrasound guidance. We place an ultrasound probe in the vagina and we can visualize the ovary. Again, this is an ultrasound photo. This is the ovary, these dark circles. These are the follicles that have the eggs inside. And under direct visualization, we place a needle. If you look here, this is the needle actually. It's going into this follicle, which has the egg inside. And then this needle is attached to a suction tube that aspirates the fluid out of that follicle. And with that fluid comes the egg. So that fluid is collected into this test tube. And once that test tube is filled with the fluid coming out of the follicle, we hand that test tube over to the embryologist. Then they look at the fluid under the microscope and let us know if indeed there is an egg. This is what an egg looks like on this side. Again, this is another photo of two eggs. Essentially, the embryologist will let us know, yes, there are eggs. We continue the procedure until all the follicles are aspirated of their fluid. And once we're done with that, we remove the needle and we allow the patient to recover. Usually the recovery is about half an hour to an hour. Once they're fully awake, they're able to walk, talk, eat, then that patient goes home. So one of the frequent ways that we fertilize the eggs is a technology that we refer to as IVFxc. You may have heard of this. It's a variation of IVF. IVFxc stands for intracytoplasmic sperm injection. So if you look here in this slide, this is an egg right here in the D section. And this is under the microscope. And by the same visualization, if we look at A, this is a sperm. So with this technology, what we're doing is we're hand selecting the best looking normal sperm in order to place that sperm inside of the egg so that that egg will fertilize. So the egg here is fixed on a staging pipette. The sperm, the most normal sperm, is identified, and using a small needle, a small micro needle, that sperm is loaded into that needle, and then that needle then is advanced into the egg with the sperm right there, and then the sperm is dropped off and this needle is removed. In so doing, we're able to know for sure that that sperm actually was able to enter the egg, and it increases the likelihood that that egg will fertilize. And in some cases where there is a male factor or other factors that could reduce the likelihood of fertilization, IVFxc is clearly beneficial in helping that couple, conceive, or helping that couple end up with a normal fertilized egg. Again, this is what it looks like, and just for reference, this is the staging pipette. This is the micro injection needle. And for comparison, this right here is a hair follicle from our head. So just this gives you an idea of how fine and how delicate these these instruments are that we use just to make sure that things are handled very properly. Once the fertilization is done, whether through conventional fertilization or IVFxc, then we allow the embryos to develop. Our goal is to have an embryo develop to a blastocyst stage, which a fertilized egg becomes a blastocyst somewhere around 5 to 6 days later. So, this photo right here corresponds to this drawing right here. This is a fertilized egg. The way we know that this is a fertilized egg is because it has 2 pronuclei. Each one of these comes from one parent. Again, we look here under the microscope. These are 2 pronuclei. A day later, or that cell then divides into 2. And then, by day 2 or day 3, we have an embryo that is 4 cells. By day 3 or so, that embryo now has become 8 cells. You could see here. After that, it begins to develop and results into, on day 4, a ball of cells that is referred to as a morula. By then, counting the cells may be difficult because it's a sphere of cells and it may become difficult to see the individual cells. By day 5 and 6, we have a embryonic structure that's referred to as a blastocyst. A blastocyst has 2 parts. It has a trophectoderm, which is the cells that are lining the outside of the embryo, and then an inner cell mass. An inner cell mass is this, which ultimately becomes the body of the fetus. And by the blastocyst stage, that embryo is ready to implant. At that point, we either place that embryo back inside the woman's uterus or a surrogate carrier's uterus, or oftentimes what we do is we do a test called pre-implantation genetic testing, and then freeze the embryo for that embryo to be transferred into a uterus at a predetermined day sometime in the future. At the blastocyst stage, the embryo has more than 200 cells, and pre-implantation genetic testing is something that is very important and useful. However, we'll talk about that on a different day during a different presentation. So just to let you know, IVF is relatively new. It was first done successfully in 1978 in the United Kingdom. There were 2 pioneers, Dr. Patrick Steptoe and Robert Edwards, who were the scientists who worked together to make this happen. Louise Brown was the first baby that was born through in vitro fertilization. Louise Brown currently is herself a mother and an advocate for fertility related. I've had the honor of meeting her several times. And essentially, this is truly, an amazing breakthrough. The first successful IVF in the United States was done in 1981. And again, this came, was a big fanfare. The baby ended up on the cover of Life magazine. Again, I worked on a panel with her. This was a few years ago at our ASRM meeting. She as well works in the fertility world, in the United States. So it's also in 2010. Robert Edwards received the Nobel Prize in Physiology and Medicine for being the inventor of IVF. Again, it's very pleasing to see that something that we do on a daily basis, multiple times a day, it is such a big breakthrough that was worthy of a Nobel Prize award. Of course, Patrick Steptoe had passed away by then, and that's why it was Dr. Edwards who was the only recipient of the Nobel Prize, because in order to receive a Nobel Prize, a person has to be still living. Let's shift gear now and talk a little bit about third-party reproduction. We'll start by talking about egg donation. Egg donation is when a person who doesn't have enough eggs, so hence they would need the use of the eggs of another person, presumably a younger woman who has healthier eggs that can potentially result in a healthier embryo and a healthy baby. So reasons why a couple or an individual may choose to use an egg donor is if they themselves as a woman have diminished ovarian reserve or premature ovarian failure, where the ovaries have for some reason completely run out of eggs before the time of menopause. There's also some genetic conditions where an individual may have, where if they were to be using their own eggs, they may be passing on that genetic condition to their child, and that genetic condition, if it's very severe in nature, it could be very detrimental to the health of the child. So in those cases, oftentimes it is advisable to consider using an egg donor from a donor who does not have any genetic conditions that can adversely impact the health of the baby. Of course, in some cases, an individual or a couple who's gone through multiple IVF cycles and for whatever reason they have failed, and it's determined that it is as a result of the egg, then considering the use of an egg donor may be helpful, if appropriate in that case, in assuring that they have a healthy child. Of course, advanced reproductive age. I mean, the reproductive aging is a natural process that is taking its toll on both men and women. So as we all age, our reproductive potential does deteriorate. This is more pronounced for women, however, and it is absolute because women are born with a finite number of eggs at birth, and after birth, no new eggs are made. And that number of finite eggs over time is declining. And we get to an age where the amount of normal eggs in the ovary that are left is very low or non-existent. So in that case, that woman or couple can overcome their inability to have a child by using eggs from a donor who is younger and preferably at their peak of their reproductive potential. And of course, as we touched upon, history of poor quality embryos from previous IVF attempts, all these are reasons why a couple or an individual may choose to use egg donation. Of course, for single gentlemen or for men who are in same-sex relationships, using an egg donor is essential in order to create an embryo with which a surrogate carrier could carry, and that individual or gay couple can have a child. So, an important step once the decision is made that that individual or couple is going to use an egg donor is selecting the egg donor. And this is very, very important for people to consider because in reality, the egg donor is going to be genetically 50% of your future child, or that individual or couple's future child. So it is very important that that person or couple spend some time really selecting their donor carefully. So there's a number of ways that egg donation can be done. One of them is a known donation or anonymous donation. Known egg donation is done where an individual or a couple knows that egg donor. It can be a friend or a family member, and so on. So in those cases, that egg donor that has been identified would need to see the doctor, make sure that they fully understand the process, and make sure that they're an appropriate candidate for to go through the process, and then they could move forward. An anonymous egg donation is when a couple selects an egg donor most of the time through an agency, a reputable agency, we hope, who is experienced in these. And of course, the role of the agency is to match that a donor with that individual or that couple's preferences, and then proceed accordingly. Of course, we want the egg donors to be of legal age so that they make their own decisions. The ideal ages are somewhere between 21 and 34. As a general rule, the younger they are, the better they are. Of course, proven previous fertility is preferred, but not required. Also, in some cases, an egg donor can be shared between two couples under certain circumstances, if that is something that all parties agree upon. Now, once a donor is selected, then they have to go through a screening process. Personally, I meet with all the egg donors of my patients personally to get their detailed medical, surgical, and social histories. We ask about past reproductive history, menstrual history, any type of family conditions, family genetic conditions that run in the family. I do a comprehensive physical and pelvic exam, make sure that they are healthy and there aren't any signs or symptoms of any type of communicable diseases, infectious diseases, or any type of substance abuse. Also, a comprehensive genetic testing is required, where a carrier testing is done to make sure that donor isn't a carrier of a type of a genetic condition that can be potentially passed on to the child. We also do this genetic test on the intended parent, on the male partner, just to make sure that the genetic profile of the donor and of the male partner are compatible, and there aren't any issues with risk in passing on those potentially harmful genetic condition to the child. Of course, donors also have to go through a psychological evaluation, and we work with mental health specialists in that realm who are experienced in this, in this area, and they just make sure that the donor is doing this for the right reasons, and there aren't any red flags in the process of evaluation. So again, just as a review, this slide just shows all the various things in more detail that we look at. We get a complete history evaluating risks of various diseases, including HIV, sexually transmitted infections. We screen for any type of communicable diseases, HIV, HTLV, hepatitis B and C, chlamydia, gonorrhea. We look for any recent tattoos and piercings, and make sure that they were done done in licensed facilities. We look for signs of IV drug use, and there's a detailed questionnaire that the donors have to fill out that is mandated by the federal government, and this is under the oversight of the Food and Drug Agency, which is a federal agency, and similar type of rules and regulations that apply at the highest level that include organ donation also apply here, because theoretically we're taking biologically alive cells from one person and placing them in a third party. So a very strict set of guidelines are placed, which we agree with and follow, just to make sure that we minimize the risk of any type of diseases to our intended parents. Surrogacy is also another third-party intervention that we often have to resort to. Indications for surrogacy is any woman who has some sort of medical condition that prevents them from being able to be pregnant or carry a healthy pregnancy, or if there is any type of issues with the uterus, whether it be a congenital issue where there was a problem with the uterus from birth, or as a result of things that have occurred after birth. Common issues with the uterus that we often encounter, where we have to resort to surrogacy if a woman has had to have their uterus removed because of cancer, cervical cancer, uterine cancer, sometimes because of fibroid tumors. Fibroid tumors are benign tumors. However, sometimes they cause such serious pain or bleeding that can be life-threatening, and sometimes they have to be removed. Any type of scarring of the uterus for whatever reason from previous surgeries or infections sometimes can make that uterus not hospitable for a normal pregnancy. So in those cases, oftentimes we have to resort to using a surrogate carrier for those intended parents or parents to be able to get pregnant. Sometimes we use surrogacy for elective reasons, for whatever reason a couple would like to, for personal reasons, use a surrogate carrier, and that's fine too, in the proper with the proper understanding. Of course, surrogacy is a common a method of procreating and having a child for single men or gay couples, gay male couples, where once embryos are created using an egg donor, then a surrogate carrier would be needed to carry that pregnancy. And of course, screening a surrogate carrier is just as stringent. We do a full medical and reproductive history and a complete physical and pelvic exam. We evaluate the uterine cavity of the surrogate carrier either by office hysteroscopy or an ultrasound test that's called a saline infusion sonogram. We like to screen our surrogates just like we screen all of our intended parents who are going to conceive themselves. We do a standard preconception testing, making sure that they don't have any medical conditions that would make pregnancy difficult or complicated. These include checking their thyroid function, checking their vitamin D levels, screening for diabetes, and any other type of medical conditions. We also want to make sure that they're up to date on their vaccinations and they are immune to certain type of infectious diseases that if they were to be infected by those diseases during pregnancy, it could cause birth defects. We just want to make sure that they are immune to these, and these include rubella and chickenpox. And of course, a surrogate carrier would also have to go through a psychological evaluation. Other things that we take into account in their history of a surrogate is how many previous pregnancies they've had. Were they by vaginal delivery or by C-section? And also matching the surrogate with the appropriate intended parents based on their beliefs and their preferences is also very, very important. And these are all things that intended parents should speak with their surrogacy agency to make sure that their preferences align, their values align, whether if they want to place one embryo or two embryos, their preferences of a singleton or twin pregnancies, their preferences of pro-life or pro-choice, or what would happen in the event if there are abnormal pregnancies and terminations. These are all very, very important factors that couples, intended parents, or individuals and their surrogates should consider in detail and make sure that they have a clear-cut plan as they choose their surrogates. So the surrogacy process essentially is very similar to an intended woman who is looking to get pregnant. It entails using a frozen embryo transfer approach. In this, what ends up happening is we begin to prepare the uterus with the onset of menses, the medications that we use to prepare the uterus so that it is at its ideal level of implantation are estrogen and progesterone. Typically, we use estrogen for about 2 weeks, and we monitor that surrogate carrier several times a week to make sure that their uterine lining is growing very well, and also to make sure that their estrogen levels are at an ideal level. Once it is determined that the uterine lining is at a perfect thickness, preferably 7 to 8 millimeters or above, and displays the ideal morphology, which we refer to as a trilaminar pattern, then we ask that surrogate to start taking progesterone, and subsequently we do the embryo transfer approximately 6 days later. And then after the embryo transfer, we do a pregnancy test approximately 2 weeks later. And, most of the time, if we have a healthy, normal embryo that we place, that test is positive. We subsequently monitor the surrogate through the first trimester until we determine that that fetus is growing normally, the body looks normal, the heartbeat is normal. Then we transfer the care of that surrogate to a general obstetrician who will provide the prenatal care and deliver the child. Selecting the proper surrogate is very, very important. I really should emphasize this. This is somebody who is going to be carrying your child, and intended parents or parent should be, should be very, very comfortable with this. Also, it's very important to work with an experienced clinical team and an agency who really know how this process goes, what are the potential pitfalls, what are the potential hurdles that need to be, that can potentially pop up along the way, and that, that both the clinical team and the agency are experienced in, in overcoming this. So that I really would emphasize and make sure that intended parents should do their research and make sure that they are in the right hands. I think with that, I'm going to stop. That is the end of the clinical presentation, and I believe we'll take questions at the end. Is that correct?
Yes, Dr. Sepilian. And in terms of surrogacy calls of future conceptions, recently, because of the pandemic, we did a little bit this time too. So The price range on this slice, you can take an additional 5K off of it. So pretty much what the fee is used for is, of course, surrogate screening and division fee or agency fee. That entails their background check. We pay a private investigator to look for all the county, state, and federal level court to see if she has any criminal background. We pull their driving record to see if there's any reckless behavior, as well as a soft pull on credit, their personal credits to see if she has any outstanding debt that could be, because we don't want the finance to be the primary motives for her to become a surrogate. Legal fees, that costs about somewhere between 10K. That consists of the drafting of the surrogacy contract for the IPs, and we will have to find another independent attorney to represent the surrogate to review the contract with a surrogate. And right after they graduate from IVF clinic, there's also especially in the state of California, it's not different from state to state, but in California, there's a order, so pretty much a process to establish the parentage. In some other states, it could be post-birth, but the total cost is about 10K. So that's the and the surrogate benefit package including the base compensation ranges from 3K all the way to, it could be as high as 50, 60 for experienced surrogate. There's monthly miscellaneous allowance to cover your food, gas, the mileage you use to travel between clinic and home, etc. Maternity clothing allowance one time. As you getting deeper into the process, you might need to buy extra maternity clothing to fit the need. Um, and as well as small trivia stuff like housekeeping, childcare, travel, all that will be reimbursed or as part of the certain benefit packages. Certain insurance is that could vary. Um, when you enter a surrogacy agreement with the intended parents, if the time is right, we will be able to utilize the open period to get her normal individual health plan. If she fell outside of that open enrollment period, we might have to go with a more expensive options. For like Lloyd's of London, and other options to resolve the to cover the surrogate maternity care cost. Okay. And surrogate screening and matching process, of course, it's fairly straightforward and simple here. So when after you submit your intended parents application, we do the background check. You will do automatic examination in clinic. Because when you get to us, chances are pretty good that you already met with a doctor, did the baseline blood work and all that. And we do have an online database for you to choose your surrogate. I'm gonna do a quick call to action here, so you can you'll be able to see the link. So if you go to your screen and click on learn more, that leads to our surrogate database, and you can use the filter on the left hand side to choose the minimum age, maximum age. Those are all pre-screened surrogate, meaning we already obtained our medical records. We have an on-site full-time nurse practitioner to screen all the medical records to make sure her conditions comply with the ASRM carrier standard. And of course, if you're interested in the end of the carrier, click on their but for you to view their detailed profile, you need to sign up with us, we do a quick vetting process, and you'll be able to see the detailed profile. So that consists, that constitutes step two, and step three. Once you selected a surrogate, we will arrange either in person if you guys live close to each other, or more commonly we do a Zoom call or whatever instant messenger or a video conference tool that you prefer. Just what Dr. Sepilian mentioned, some of the background, especially we seen in the past, a Christian couple match with a Christian surrogate that they read, scripture to each other. Those are the good representation of how important it is for you guys' background, your belief, your political views, like either pro-life or whatnot, that match each other. Very commonly we ask surrogate, are you opting for selective reduction? If you have, some of the surrogate have a strong religious belief, we will choose no on that answer. So we will choose, we will help them to find IPs that have a similar belief. And step four is medical cycle. Dr. Sepilian already, give you a very detailed interpretation of what that consists of, what type of testing need to be done. Legal process, I think I already touched that briefly in the previous slides. There's a surrogacy contract review, and also the pre-birth court order to establish or post-birth to establish the parentage. Step six is to get pregnant. Um, Same here. Dr. Sepilian already explained, what's going to happen prior and post the transfer, and what type of medication you need to do, what type of injections. And step seven, of course, after 10 weeks, approximately 10 weeks at the IVF clinic, you will go to a normal OBGYN and eventually deliver your baby a normal hospital. So really, at the IVF, it's only the 10 weeks of the first 10 weeks of your pregnancy. Financing and preconception, we understand surrogacy is, it can be very, very expensive. So we do offer several options. We do partner with Prosper Health Lending or live stream at Sun Trust to offer you financing options. But before you even get to that, if you have we make sure you talk to one of our client relations. So definitely there are better options than those specialized financing. For example, if you have a house and have a good amount of equity on it, a cash out refinance will get you much lower interest and a longer term. Our client relations will help you answer those questions and help you choose the best option to finance your surrogacy journey. Okay, so Dr. Sepilian, I do have our a webinar live stream to YouTube and Facebook at the same time, but we're gonna go over the questions on the screen first. Then I'm gonna see if we have any additional from Facebook and YouTube. Um, the first one is from James, Mr. Barnes. Would ultrasound um, would ultrasound make some harm on vagina or womb? I don't know what type of that's a question he asks.
Yeah, there's multiple. The process of IVF requires us to do multiple ultrasounds. These are very directed pelvic ultrasounds that we do to look at the uterus and ovaries. There is no evidence at all that ultrasound causes any harm to any organ, any of the reproductive organs, and it is something that we do regularly and frequently without any indication that it causes any harm.
All right. Okay, and it's from Mr. Barnes again. So, do we need to undergo some testing for egg quality? I think this is when it happens when you talk about the egg quality, the basics of IVF, and so he's asking if the egg quality will be tested.
Yeah, that's a very good question, Mr. Barnes. And again, for the sake of keeping this presentation very focused on IVF, we didn't talk about the workup that takes place when a couple or an individual comes in who's experiencing infertility. Indeed, the egg quality and quantity are one of the most, if not the most important factor that determines success with IVF, whether it be an individual or a couple using their own eggs, or an egg donor, or successive surrogacy. So the biggest driver of success is egg quality. So before we start, we do several tests that give us an idea of, what is the egg quality and quantity. The number one predictor of egg quality and quantity, which oftentimes go hand in hand, not always, but oftentimes go hand in hand, is simply age. So age is the biggest determinant of egg quality. And what we do is um, based on that, we already know how to advise a couple. Then there are some tests, ultrasound being one of them, as was mentioned, where we do a pelvic ultrasound to look at the ovaries and count the antral follicle count. So antral follicle count is looking at the ovaries when they are at its resting phase in the beginning part of the cycle, and to see how many of those small follicles, remember the follicle we said is a fluid-filled sac that contains the egg, are available that month. There's also some more objective ways of testing ovarian reserve or egg quantity and quality by doing some blood tests. And common blood tests that we do to assess this is one that is called measuring a hormone that's called anti-Mullerian hormone, or AMH, as well as follicle stimulating hormone, or FSH, which is typically done on the second, third, or fourth day of a woman's menstrual cycle. All this information we can put together. They're important pieces of the puzzle, which we put together, and then we're able to assess what the egg quantity and accordingly quality is. And then, of course, we would advise that individual or couple accordingly.
All right. Okay, the next question is for known egg donation, they cannot be relatives, right? Basically, he's asking if if the known for for known egg donor, can they be relatives?
Uh, Actually, they can be relatives. It's not unusual for known donors to be relatives. For example, if for whatever reason a woman has developed ovarian failure, but they have a sister who has normal eggs that can donate. This is the sister of the female partner, not of the male partner, obviously. In that case, it's not unusual where a sibling or a cousin or another family member who is not biologically related to the male partner, of course, then they can serve as the egg donor. Same thing can go for surrogacy as well.
All right. And the next one is IVF painful?
So IVF is a process, typically, and it can take anywhere from 4 to 8 or 10 weeks and has different steps to it. IVF requires 2 procedures to be done, and one of them is the procedure to remove the eggs from the ovaries, and the second procedure is placing the embryo back inside the uterus. Now, the procedure where we remove the eggs from the ovaries, that can potentially be painful. However, that procedure is done under sedation. So Typically in our center, another doctor is present for that procedure as well. So there are two doctors in the room. The other doctor is an anesthesiologist, a board certified anesthesiologist. And the specialty of that doctor is to make sure that the patient is completely comfortable and also that patient is completely safe during the procedure. So that doctor will typically start an IV and provide some medications through the IV so that the patient who is going to undergo the egg retrieval procedure, whether it be an intended parent or an egg donor, is comfortably asleep but breathing on their own, and that they're totally don't feel the pain at all. So the procedure, depending on how many eggs there are, takes somewhere around 10 to 20 minutes. And once the procedure is done, we wake that patient up and they recover. The anesthesia doctor will monitor them as well, just to make sure that they're fully awake, they're free of pain, and that's when they are sent home. So essentially, of course, it's from time to time, there are cases where somebody may feel a little full or crampy or a little bit sore after the procedure when they go home. Most of the time, all they need is Tylenol. Just a little bit of Tylenol takes care of that pain. Now, the second procedure, which is when we put the embryo back inside the uterus, that is not painful at all. That actually just feels like a pap smear. It may be uncomfortable because we use a speculum, a vaginal speculum, just so we can see the cervix and through the cervix place the embryo. But the patient does not need any medication at all for that procedure, and she's fully awake. Oftentimes, their husband or partner is also in the room. That procedure is done under ultrasound visualization, so the couple can watch live on the screen the embryo being placed inside of the uterus. So from that aspect, the egg retrieval procedure is potentially the most uncomfortable. However, we use medications to make sure that there is no pain.
Right. And the next one, um, should I stop smoking during the IVF if I have a TB? Is it possible to make IVF?
Yeah, I mean, the answer to that question, should I stop smoking, is always yes, regardless of IVF or no IVF or any other condition. Smoking is one of the worst things we can do electively to harm our health. Many people know that individuals who are smokers are at higher risk of developing, lung disease, lung cancer, heart disease. But, many people don't know that smoking can really adversely impact health, reproductive health, both for women and men. Even men who have normal sperm, if on the semen analysis, can have microscopic damage at the DNA level because of smoking that we have no way of knowing. So by all means, stopping smoking is one of the best things a couple or an individual can do to help their reproductive health and their health overall. Presumably that individual or father-to-be wants to be around a long time to be with their child and so on. And stopping smoking is one of the best things they can do, period.
Okay. And the next one is, would uterus, I think this question came out when you talk about the surrogacy process, doc. So she's asking, would the uterine tissues affect surrogacy process and the baby? Uterine issues. I'm sorry. Uterine issues.
Oh, absolutely. Uterine issues are one of the things that we want to screen for when we're selecting a surrogate carrier. And some uterine issues we're able to know just based on history. And the pelvic ultrasound that we do, we take a close look at the uterus to make sure that that uterine cavity is free of any abnormalities. We also do an evaluation of the inside of the uterus, whether it be by putting a small camera inside and looking directly, which is called an office hysteroscopy, or another way of doing that is a special kind of ultrasound where we put a very small, flexible, soft catheter inside of the uterus. We place some sterile saline fluid so that the uterine cavity is distended, and then we're able to examine the inside of the uterus. If there are any uterine issues, then we're able to see, to determine those. And if they're not, if they're severe cases, then we would disqualify that surrogate carrier.
Right. I think Doc, you already answered the next question. They were asking the negative. What are the factors that can negatively impact the IVF success rate? So the next one is also curious how long would it totally take for physical testing, like before surrogacy? If the testing failed, is there any solution for that?
Well, it really depends on what it is. It's not I mean, these are, we really have to keep in mind that these are not a one size fits all type of a situation. Um, each intended parent or each surrogate carrier brings their own unique type of circumstances, and we approach them as a unique individual. It's not one size fits all. Yes, there is a standard set of tests that need to be done, but we have to take that individual as an individual. Like, for example, if there's a potentially reversible condition, then we could work with that surrogate to reverse that condition and until that it is resolved, and then we can move forward accordingly. Common things we see that concern us are lifestyle factors, BMI or body mass index or body weight. Um, Somebody brought up smoking. Obviously, smoking is potentially a modifiable condition that can be done. Let's say if a surrogate carrier is not immune to a certain infectious disease that can potentially harm the baby, then we would advise that surrogate carrier to be vaccinated. And once they're immune, then we can move forward. So, each surrogate or intended parent brings to us a unique set of circumstances that we evaluate thoroughly, and then accordingly we make the determination if this is something that we should approve or is something that we would advise that intended parent to potentially select the different surrogate.
All right. I think the only other question that come from other channel is from the YouTube. So they were asked. So one customer, one of the audience is asking, how much it cost to do IVF cycle at the PFCLA, and also he wants detailed information on the egg donor and surrogacy packages at PFCLA. Yeah.
Yeah, I think that those are very good questions, and we have financial counselors that you can reach out to that can go with that. You can visit our website and call the office, and we can, by all means, direct you to one of the financial counselors. There are packages, multi cycle packages, and so on. But yeah, that's something that you can make an appointment with one of our financial counselors who will give you the detailed, exact information.
All right. And I'm gonna send a call. I'm gonna send a button on the center of your screen. So any of the audiences, if you like to schedule, if you like to learn more about the financial cost, or any financing options at the PFCLA, you can click on the button "Learn More" to go to PFCLA's website, or you may also call their office. They have two numbers. One at the Westwood office is 310-853-1440, or Glendale office at 818-925-7875 to schedule consultation with the medical team. I think I don't see any further question from any of the channel. Thank you so much, Dr. Um, Sepilian, for joining us. It's a very informative session. I hope all of the audiences uh, have learn learn something about IVF and surrogacy from the slides. Um, yeah, thank you so much for attending. Any further question, feel free to contact us via social media or a website, or call us directly.
Thank you. Thank you very much. And thank you for being with us. Take care. Have a great day. Be safe out there, please.
Right.